Welcome to BJS, British Journal of Surgery. We're here to discuss the surgery in the elderly issue, and we're here at the Vascular Society of Great Britain and Ireland in Bournemouth. I'd like to welcome Professor Martin Björk from the Department of Surgical Sciences, Uppsala, Sweden, Professor Bruce Campbell, vascular surgeon from Exeter, and Professor Mike Goff, vascular surgeon from Leeds. And I'd also like to introduce the co-editor-in-chief of British Journal of Surgery, Mr. Jonathan Earnshaw.
Thank you very much. We've designed a special issue. We have a special issue every year of BJS that is published online only. And the issue we'll be making next year focuses on surgery in the elderly. It contains a number of leading articles and some reviews that we've commissioned. It also contains some original articles sent in by our surgeons. And it's be free to download early in January.
And you've written a leader on vascular surgery in the elderly. Can you tell us a little bit about that?
Yes, vascular surgery is really surgery of elderly people, as you know very well, Rob, as a vascular surgeon. We wrote the leader together to highlight two things. First of all, the surgery of vascular disease is the surgery of the elderly, so we have to be cognizant of that when we're dealing with our patients. And as our patients get increasingly elderly, there comes the problem that how do you manage very elderly patients with often emergency vascular conditions? The second thing is, on the elective side of vascular surgery, much of what we do is preventive. We mend aortic aneurysms before they rupture. We treat people with carotid disease to prevent them having a stroke. And as our patients are getting older and older, some of the decisions are getting extremely difficult about when we should take age into account as treating vascular patients. And that's really why we're having this discussion this morning.
So the leader in vascular surgery in the elderly raised three very interesting case scenarios. And the first case scenario is an 87-year-old woman who lives in a residential home with an asymptomatic 7-centimetre abdominal aortic aneurysm. This had been detected during ultrasound examination for treatment of an assessment of urinary tract infections. She's previously had a myocardial infarction and she can walk with the aid of a stick but doesn't walk outside. Martin, what would you think is the best elective care for this patient? And what would you do if she presented with a ruptured aneurysm?
I think this is a very difficult situation because it was easier before when we had only open surgery. Now we have endovascular repair, which is an option. Of course, to make the right decision in this case, you would need to know if it's available for a standard EVAR. We had a similar case in Uppsala half a year ago, an 86-year-old woman with a 7-centimetre aneurysm, and we had a very thorough discussion with her and the family and decided not to operate on her. But and that was a good decision. Everyone accepted it. But she did rupture 3 months later and died from rupture. And we must recognize that a 7-centimetre aneurysm in a woman has an extremely high rupture risk. So of course if we don't operate on this woman, she will most likely die, maybe within a year. On the other hand, if we do operate on her, we might destroy that last year of her life. So those are the two things we have to counterbalance. So you would like to evaluate both the cognitive function and the cardiovascular function, but most likely I would not operate on this patient electively.
And do you think age plays a significant role in that decision-making process?
It does, because age is very associated with high complication rates and high mortality on a group basis. But of course, this is an individual patient. You have to make an individual decision. It seems, though, that she's walking with a stick, but however, she could have a hip problem or something that maybe is not that important for the outcome of surgery. So you have to really find out, why is she walking with a stick? Why is she not walking outside? And what is her quality of life? So really, this is only the beginning of the story. You have to be meticulous in finding out more about this patient.
Martin, one of the leaders in the special issue on surgery in the elderly is from Jeff Lunn, who is a palliative care surgeon in America. And he is somewhat critical of our discussions with patients where we regard diseases as a battle. So if you choose to decline surgery, you're losing the war, it's cowardice. Is there ever an age at which you would decline to intervene on somebody with an elective aneurysm for whom the patient and the family were keen for you to do something? But for example, the man or the woman is 95 years old. Would you ever say, look, I'm not prepared to operate on the grounds of age alone?
I think the 95 is, of course, an age where I would never do an elective repair. But, you know, we've been moving, this age limit has been moving upwards. When I started long ago, 70 was the age limit. And now we're at 85 maybe. So with new technology and also more fit patients, we must recognize that the elderly often are very fit, and the above 80 and also above 90 are sometimes very fit.
Can I comment at the outset on what I see as the big difficulty with just age? Because in the UK, for example, we are at the moment entering into a phase where any kind of discrimination on the basis of age alone is something we shouldn't be doing. And the problem is that age is often used as a surrogate for frailty, for comorbidities, and for that kind of thing. And so it is very difficult talking about age alone. And really what we're looking at is whether a patient of a certain age has comorbidities, whether they are, in inverted commas, frail, which may be difficult to define. And I think all those things need to be taken into account. Age alone, I don't think you can, in this day and age, ever use as a total cut-off. It's other factors as well.
I think most people would agree with that. I think one of the caveats is that most of the risk prediction systems include age as an independent factor for subsequent complications and mortality.
Can I introduce one other thing, which is resources? We are supposed to be living in an age of austerity where we have a cash-limited health service. Is it the sort of, do you think that it's the sort of thing we should be doing from that perspective, operating on people who are very elderly to do preventive treatment?
Well, globally speaking, of course, those priorities have to be made. Fortunately, in Sweden, where I work, we are not forced to that yet. There are no such mechanisms. If we think that the patient benefits from surgery, we are free to operate on that patient.
Can I just change track slightly and ask you, if this patient presented with a ruptured aneurysm, so you turn them down electively, would you offer repair on a ruptured or emergency basis?
Well, by and large, my policy is not to turn anyone down for emergency repair unless there are clear reasons where their life expectancy is extremely short anyway. If they've got, say, renal failure pre-existing or malignancy or whatever, disseminated malignancy. But by and large, if they get to hospital and they've still got a blood pressure, I tend to operate on them. Although, of course, we may stent them now.
I'm going to take issue with Mike over that, because I think you've almost got a moral duty that if you make a thoughtful decision about not operating on somebody electively, I think part and parcel of the management of that patient is actually looking them in the eye and talking to them about rupture, because if they've been able to make the decision with you they don't want elective care, and they hear what's involved with a rupture, they're likely to say, I certainly don't want that. And
that's a patient decision. You said if they don't want repair.
If the decision has been made not to repair them, which is the question that was asked, you know, if you turned this patient down for elective repair, would you operate on them if they ruptured? My answer is a firm no, but I think that plan has to be made beforehand. And I think part of your communication with primary care about such a patient is, we've agreed not to proceed with elective repair, therefore, if this patient ruptures, she should be treated kindly with analgesia and good palliative care at home. I think it's part and parcel of the decision.
Well, I'm not sure about that. I bet we've all operated successfully on a rupture who's previously been turned down for elective repair.
And we're talking here about survivorship, aren't we? But what about the issue of independence, Martin? Specifically, these patients who have dependence within residential homes.
This is, of course, becomes problematic if you choose not to do the elective repair and the patient comes with a rupture and you decide to operate anyway. And then, of course, the risk of that patient ending after surgery with worse functions and maybe needing to move to a dependency unit becomes an issue that maybe would not have been an issue if you had done the elective repair. So because the ruptured situation is much different and is a tougher situation for the older patient.
I'd like to introduce the second case, which is an 85-year-old man who lives with his wife. He had a fall and developed some right leg and arm weakness 10 days ago. A CT scan has confirmed a left cortical infarct, and duplex imaging suggests a left internal carotid artery stenosis of 70%. However, his wife says he's become increasingly confused over recent months, and his GP confirms that he's been investigating the patient for suspected dementia. Professor Goff, how would you manage this patient?
I wish you hadn't mentioned the dementia. On the face of it, let's simplify it slightly to start off with. And if you've got an 85-year-old patient with a symptomatic carotid stenosis, then they certainly justify treatment. The risks of surgery in that age group from carotid endarterectomy are perhaps 1 or 2% more than the average, but the actual risk benefit, the risk reduction in terms of stroke in people over the age of 80 is massively greater than it is for someone aged 65, about 3 times greater. I know Peter Rothwell once said that even if the operative risk was 10% for carotid endarterectomy, there's still a benefit to doing it in this age group. So that's a very straightforward scenario. And the fact that elderly patients do well from carotid surgery is not really surprising, because there are no hemodynamic changes intraoperatively like there are, when we were talking about aortic aneurysms. It's really quite a trivial procedure, isn't it? Now, the issue of dementia is a little bit more difficult. There's no evidence that carotid endarterectomy improves cognitive function. So will his dementia get better if you operate on him? Then almost certainly not. So the fact that he does have dementia isn't an additional reason for doing the surgery. There is one paper which, rather like our own HQIP system from the States, the Surgical Quality Improvement Program, did show that if patients are fully independent, or they graded patients into fully independent, partially dependent, and totally dependent. The middle group, the partially dependent, so needed some help with daily activities, they did have a significantly higher death and stroke rate than fully independent people. So if he has got dementia, his risks from surgery are higher. Personally, you should never suggest either to the patient or the relatives that their dementia will improve following carotid surgery. But I think he's living at home, probably with minimal support. There's no reason not to offer him treatment.
You carefully skirted round whether carotid surgery causes cognitive decline. I think there's a number of studies on that, and stenting, that show that that's a possibility, perhaps more so with stenting.
Well, it would be attractive, as all carotid surgeons would say, it would be very attractive if we could prove that carotid stenting caused a decline. There is actually no real evidence at all that it causes a decline. The nearest we come to that is if you extrapolate Ross Naylor's data on multiple emboli intraoperatively. In other words, Ross did a study on cognitive function, and the people with multiple emboli did show a measurable reduction in cognitive function. And then if you say, well, if emboli are the cause, then stenting is bound to cause emboli, therefore it must cause a decline. But that's actually not proven.
Professor Bjork, how would you manage this patient in Sweden?
Well, I agree with Mike that stroke prevention is greater in the elderly. There's lots of evidence on that. So this patient carries a high risk of stroke if we don't operate. And the stroke prevention sort of capacity of a carotid endarterectomy is greater in this patient than in a younger patient. So that would speak to operate on him as quickly as possible. Regarding dementia and vascular disease, I agree that dementia will not improve by this procedure, but actually this patient may suffer from vascular dementia. And it's very difficult to distinguish vascular dementia from Alzheimer's disease. The neurologists tell me that this is almost impossible. And there's also lots of research going on trying to define the vascular component on Alzheimer's patients. And it seems that there are a large group of patients that have a mixed etiology of dementia with both vascular disease and Alzheimer's disease. And I think we will in the coming years learn more about this. There's lots of research going on. So in that case, maybe the carotid stenosis is part of the dementia problem of this patient. Although it may not improve, maybe it will not deteriorate if we operate on this patient. And as I also agree with Mike that elderly patients do excellent with carotid surgery. So I would not hesitate to operate on this patient.
You're sort of hinting there that perhaps we ought to be looking for carotid disease more frequently in patients presenting with dementia. Do you think that's
well, I
we
think
should do?
it's a potential area of research, but then in terms of asymptomatic stenosis. It is possible that patients with asymptomatic carotid artery stenosis and dementia would benefit from surgery, but that needs to be studied in proper science, of course. That's just a hypothesis.
What they do benefit for is medical treatment, of course. Best medical treatment, which I don't think is always given to people with vascular dementia.
Exactly. There's an area of improvement to improve their best medical treatment. But maybe on top of that, there may be a subgroup of patients that benefit from surgery, but we don't know that.
That's the problem, the subgroup. I mean, going back to your point about asymptomatic and symptomatic, there are some studies that have measured cognitive function before and after in two groups of patients, symptomatic and asymptomatic. And they've tended more to show some improvement in the symptomatic patients, but no improvement in the asymptomatic. I think we're a long way from identifying patients with dementia or with early dementia who might benefit from carotid surgery.
To go back to the case we're talking about, I think the arguments are much more easy for age with respect to carotid surgery, aren't they? Because of the point you made earlier, that if someone who has a stroke is independent and has a stroke and becomes dependent, that's a big change in lifestyle, and it's well worth doing something to prevent that.
Yeah.
So the arguments of age then really fall away, don't they? Just on one practical point, I know that Mike, you're a local anaesthetic carotid surgeon. I don't know about Martin, but how do you feel about trying to do a local anaesthetic carotid on somebody who had mild to moderate dementia? Are there practical issues there?
Yes, I think I think there may be. I wouldn't not. Well, I wouldn't be operating on the type of dementia that you'd expect the patient, to get up off the table and go walking down the hospital corridor. My default is local anaesthetic for everyone, and that's usually combined with a bit of sedation, some midazolam or whatever. So I wouldn't be too concerned about that.
We have, during different time periods, we've been using both methods. Presently, after the results of the GALA trial and because of administrative issues, or actually lack of anesthesiologists, we do it under general anesthesia today, because then an anesthesiology nurse can be responsible for the patient. So we do almost all our carotid operations in general anesthesia today.
We have a third case scenario, an 8-year-old man who has advanced malignancy. He lives alone with daily visits from a carer, and he has a 12-hour history of a painful ischemic foot and a tender calf. He's not in atrial fibrillation. Professor Campbell, how would you manage this patient?
Very difficult, with his very grim outlook. I think one thing that I'd like to raise at this point, which we've not really talked much about before, is what the patient wants, having been counselled in detail. And I think this applies as much to this case as it did to the aneurysm case that we were talking about. That having presented all the pros and cons of investigation, intervention, what happens if you do intervene, what happens if you don't, particularly in this man who's only got weeks to live, I think sometimes the patient can actually make the decision for you. And I think giving them that opportunity is really, really important. Because if the patient says, look, I'm fading away, my wife died 2 years ago, I'm on my own, I'm miserable, please just leave me alone, that actually is the right way of making a decision and makes the decision for you. I think other patients may press, as we talked about with the aneurysm patient, it doesn't matter what happens, I want you to do something for me. But I do think emphasising that conversation and the patient's wish is important. And that's the first thing I'd say. I mean, I think the second thing to say is obviously we don't know, having just seen the patient, what the cause is. That makes it very difficult, because if we believe that this was an embolism, then the treatment could be very simple, just a local anaesthetic embolectomy, and you made the patient better very quickly. Obviously, if the patient has a thrombosis in situ, that's much more awkward, because you're then looking at lower success rates. So I think that is a difficult one. So I think the first decision needs to be, in general terms, is this a patient who is more or less dying or going to die very soon? Or is this a patient who actually potentially has some quality of life for the next several weeks and they'd like something done?
But can I ask you, so you're suggesting that you would image every patient?
No, the point is, I think, again, I hark back to the aneurysm case. One's making a clinical and humanitarian decision first with the patient about ought we to be doing anything. And if there is any doubt about that or a sense that you ought to be proceeding, yes, I think you do need to image them. Because in this particular patient, the scenario I can see here, there isn't a clear history of embolism. And I think probably imaging will then be the guide to what you next do.
Yes, I mean, nowadays it's pretty unlikely it will be a simple embolus, isn't it? Those have disappeared, the straightforward embolectomies, apart from maybe the odd brachial embolectomy.
We have a different treatment tradition in Sweden. We do much more thrombolysis in these cases, I think, than you do in the UK. If there are no contraindications in this patient for thrombolysis, we would consider that, because this is more likely that this patient has a thrombosis, maybe as a paramalignant phenomenon.
Oh, exactly.
And then the thrombolysis would be a better treatment. And it's rather non-invasive, so that we would consider.
Martin, do you think the elderly patient is a good candidate for thrombolysis, given the bleeding and stroke risks?
We have published some papers on that, and the bleeding, the intracranial bleedings are extremely uncommon. It's like 0.2% or something. So you can treat like 400 or 500 patients before you get that complication. But there is an increased risk in the above 80, above, and even more about 90-year-old for intracranial hemorrhage. That is true. But we are still talking about maybe 0.5% or 1% risk, which maybe in this situation is acceptable.
No, I'd agree with Martin, because I mean, this poor chap, he's got malignancy, 3 or 4 months to live. If you operate on him, end up doing fasciotomies or even an amputation, he's going to die in hospital almost certainly, if his life expectancy is so short. So thrombolysis would be an attractive option. You did mention calf tenderness, I think. Any neurological symptoms? Because if he's got calf tenderness and neurological symptoms, would you still go ahead with thrombolysis?
Well, we would hesitate,
it's
of
all
course.
a bit relative, isn't it?
It's
how
relative,
tender, how...
And of course, if there's no motor function and no sensitivity, then we would not go for thrombolysis. But if it's half in between, that there's a bit of neurological impairment, but he can still move the leg, then we would still consider thrombolysis in this patient. We must remember that the maybe most invasive option here is a major amputation. And if we can avoid that in this frail patient, that would be very important. We would do a CT of his brain if he has general malignancy, to rule out that he's got a cerebral metastasis, because that would be a contraindication for thrombolysis, of course.
I sense between all of you a gloom about this patient, and this case scenario is deliberately designed to set that up, because they're old, they don't do that well from thrombolysis, he's dying, and we know that this is supposed to be a thrombosis-associated malignancy, which does very badly. It's very difficult to get those anyway to work. And he's got a tender calf, which means this is relatively advanced ischemia. And I sense from all of you a foreboding that if you start intervening, it's difficult to stop, because you do thrombolysis, which partially works, and then you have to do an embolectomy to try and remove a bit of the trash, and then you have to do fasciotomies, and then you're into this scenario that we looked at, you mentioned before, which is that the patient's in hospital with fasciotomies that don't heal for 2 to 3 weeks, or which may well consume a large amount of their useful remaining life. And that's why the case was set up like this. Is that the correct way to go, or do you have to be a bit more radical and either discuss with them doing nothing at all, or maybe going straight to amputation, Bruce?
I mean, can I just make an observation before we leave lysis? I mean, an observation and a question for Mike Goff. The observation is that, I mean, my experience of doing any sort of lysis in a patient with malignancy-associated thrombosis is they rethrombose. Yeah. If they've got terminal or advanced malignancy, the rethrombosis rate is so high that actually, unlike Martin, I wouldn't consider lysis in this patient. And my question then to Mike Goff, on a more general note, is my sense is that, unlike in Sweden, my sense is that lysis is being used less in this country rather than more. We were very enthusiastic about it several years ago, but our experience of it, particularly in patients like this, has actually made us use it very, very little now. I mean, is that your sense as well, Mike?
I think we do definitely use it less, and I entirely agree that if they have a prothrombotic state associated with malignancy, the outcome of lysis or indeed thrombectomy is usually poor. I mean, I think in this particular patient, the decision is probably either to do nothing or go for amputation.
Bruce, you have strong opinions about palliative care in vascular patients, don't you? Tell us about how you would, if you decided to do palliative care in this circumstance, what would be the important components of it?
Very first, enlist the help of others who are much better at palliative care than us. enlist, for any inpatient, I would immediately enlist the help of the palliative care team, who classically we think of as dealing with cancer patients, but they actually deal with everyone and they're very good at it. If patients are going to be at home, there are other options such as Macmillan nurses. There are a whole lot of other people who bring great expertise in palliative care to bear, and I think it's desperately important to involve them. I think the other very important things are to be sure that all these things are coordinated. There isn't uncertainty about what's happening between ward nurses, the family, the general practitioner, and everybody else. So I think that the two main things are to be absolutely sure that everybody is, as it were, reading from the same hymn sheet about the patient, and to involve expertise, which we have to an extent, but not to the extent of palliative care specialists. That's really important.
I'd like to thank our panel members, Professor Martin Bjork, Professor Bruce Campbell and Professor Mike Goff, for their expert opinions and discussion today. The BJS special issue will be available online, free to download in January, as will this podcast.